We'll now move on to the next presentation, which is Dr. Scott Nightingale. Young Scott grew up in the Hunter Valley, and his talent was obvious fairly early in the piece because he was the school captain at Muswellbrook High. And that's where he met his delightful wife, Sonia, who's a very successful GP in Newcastle, and one of the reasons why we can't get him back to Westmead Hospital as a consultant in our department. Scott did his undergraduate training in Newcastle and also his early paediatric training, and came to us for 2 years in 2008 and 9, I believe. During that time, he undertook a master's degree of clinical epidemiology, and part of that study was he had to do a project, and he looked at our experience with biliary atresia. So he put together all our patients, and then in 2010 went to Hospital for Sick Children in Toronto to continue his fellowship, and he amalgamated our data and compared it with the experience of the sick children in Toronto, and to our delight we're finding that we're every bit as good, probably a little bit better than them. So as a result of that, Scott has become the local guru in biliary atresia. So Scott himself is a visionary, always thinking about what can be rather than what is, and so it's very appropriate that he talks to us about the future of liver disease, hopefully without the need for liver transplantation. Scott?
Thanks, Ted. I was a little bit worried about what Ted might say about me because if I can share a quick anecdote, I saw a patient in the clinic who lived up our way and had a transplant, and he was very, very quiet and withdrawn. He wouldn't look at me, and I said to his mum, "Is he normally this quiet, this boy?" And she said, "Oh no, he's just worried about what Dr. Storman and what Dr. O'Loughlin have told him about you." And apparently he was told that I just got out of jail, but I think Dr. Storman had reassured him, said, "Don't worry, he's turned over a new leaf." So the boy talks to me now, so that's okay. So I'm lucky. I get a really exciting thing to talk about. Paediatric liver disease, the future. Just a bit of an overview. What we're going to talk about, where are we now, the future of diagnosis, treatment and transplantation. So we can't talk about the future without knowing about where we are now, and as we all know, currently diagnosis involves things like blood tests where we measure markers of how well the liver is functioning and how much the liver is being injured. We look at imaging, we look at ultrasounds, cholangiograms, nuclear medicine scans, and more recently MRI scans. We have liver biopsies, and liver biopsies are really the mainstay of monitoring a lot of liver diseases and post-transplant. We use them to follow rejection, and these are an invasive test. We also have genetic tests available, but unfortunately not all diseases have a known single genetic basis. And for those that do have a genetic basis, not all the known mutations are available. There's also a very long turnaround time for genetic tests. Can take weeks to even months to get answers back. And they're also very, very expensive, so hospital administrators don't like paying for them. Treatments, where are we now? We've got medical therapy, but unfortunately there's relatively few paediatric liver diseases that have effective therapy that is actually curative. More recently, Westmead, Royal Children's Melbourne and our centre in Newcastle have been involved in an international multicentre study of hepatitis C treatment for children, and that's shown some very, very promising results with oral-only therapy. So there's a couple of diseases where we can cure liver diseases, but unfortunately most paediatric liver diseases are not currently curable. There's also the side effects of the medications, and when we consider conditions like autoimmune hepatitis or post-transplant, the toxicity of immunosuppressive medications is not insignificant, and Michael alluded to that earlier today. Most medical therapy for chronic liver disease, therefore, is really supportive, and it's about nutrition and trying to manage symptoms like pruritus. We also have surgical therapy, of course, palliative surgical procedures. That means procedures that just try and get around obstructions, Kasai procedures and other innovative procedures that Dr. Shun has devised over the years. Surgical therapy as well involves transplantation, of course. So let's look to the future. That's what this talk is meant to be about. I think in the future we're going to see better genetic diagnosis, and we're already seeing that on the horizon. Each year we're seeing new rarer diseases being attributed to a genetic cause. Years ago, the proportion of babies that were cholestatic for which a no diagnosis could be made was quite large. That proportion is getting smaller each year as we're uncovering more causes, and the field of genetics has really exploded in this regard. We also have improved techniques to identify genetic mutations, and a lot faster. There's new technologies such as gene chips, which I'll talk about shortly, that allow a really fast turnaround. And in the future, not so distant future, we might foresee an opportunity where we can have almost bedside testing, testing available in smaller centres, not having to be shipped over to the US or to the UK to specialist labs. Again, I point out that not all paediatric liver disease, though, have a single genetic cause like biliary atresia, and so we have to keep working to understand the cause of those diseases. This is the gene chip that's available currently, developed by Cincinnati Children's Hospital, and they have a number of panels, and basically this allows rapid screening for known mutations for a number of genetic diseases. And so we have a number of mutations on there that include diseases such as the PFIC diseases, Wilson disease, Alagille syndrome, and alpha-1 antitrypsin deficiency. This is what a gene chip looks like. So we have literally tens of thousands of gene mutations that can be detected and fed through a computer with a single drop of blood. Even small amounts of saliva can be tested as well. So it's pretty exciting stuff. The future of diagnosis, this is not really a futuristic concept. In fact, it's an ancient concept, examining poos. The Chinese have been examining poos for health and disease for millennia. But one thing that I will mention is the infant stool colour chart. Lots of parents of infants with biliary atresia will have noticed that their infants have got pale stools, but the importance of that hasn't been pointed out to them, or nobody's asked them about that. And there's lots of jaundiced babies out there, but a jaundiced baby who has pale stools probably has liver disease. And this is a very, very simple screening test that is shown to be effective in places like Taiwan, where they introduced a stool colour chart, which is exactly the colour chart that's shown on the screen there. I think in 2002 they introduced it. They put the colour chart into the Blue Book and educated the parents, and they said, if your baby's stool looks like 1, 2 and 3 and they look yellow, phone this number. And the infants were then taken to a nearby hospital, had a single blood test. It costs about $20 or $30 to do that blood test of a split bilirubin, and they were able to detect biliary atresia infants much sooner, and hence they were getting Kasai procedures much sooner. And now we're seeing the long-term data has been published from that has shown there's been a significant reduction in the age at diagnosis, the age at Kasai, and that has actually translated into fewer transplants for children with biliary atresia in Thailand. This has also been introduced in other countries around the world. I believe Switzerland and Brazil also has a stool colour chart. There's some recent cost-effectiveness feasibility studies that have been published about whether this could be adopted in places like the US. We certainly feel it could be very helpful and work in our system as well, where routinely people have infant baby checks around the 6-week mark with the GP or the early childhood nurse. And while I'm on the soapbox, when I looked at all of the infants that have been diagnosed with biliary atresia in New South Wales, we found about 40% of them. In 40% of cases, the parents had actually presented to their doctor or their early childhood nurse or midwife concerned about the jaundice, and they'd been reassured, don't worry, it's breast milk jaundice, the baby's fine, because the baby looks fine and is growing normally, but that's before advanced liver disease has developed. So we made a submission to New South Wales Health in 2012 to have a colour chart put into the Blue Book, but that was rejected. But I think we should try again, given that there's a bit more data. The future, non-invasive diagnosis is really the goal. Wouldn't it be great if we could diagnose liver diseases and monitor them without painful, unpleasant procedures happening all the time? So our goal would be things like blood, urine or stool, or even salivary markers of liver health or disease. Obviously it would be less traumatic, faster, and we might get a more accurate diagnosis as well, avoiding repeated procedures and minimising, for example, the number of liver biopsies post-transplant. It's still a long way from everyday use, but I can tell you a little bit about a new field which is probably a hot topic in this area and where we might see something coming out, and that's in the field of microRNAs. This is a little bit of a science lesson before lunch. I hope everyone is up for this. I apologise if it's a bit dry. So we all know our bodies are made up of cells, and if we think of a liver cell being a round blob like that, every cell has a nucleus, and inside the nucleus we have DNA and thousands and thousands of genes that are switched on and off at various times depending on what the liver cell is doing and what the liver cell needs and responses to injury. What happens inside that liver cell is that DNA is actually translated or transcribed, written across to something called RNA, which then leaves the nucleus, because DNA doesn't leave the nucleus, and that RNA is like the little code that tells the cell to make certain proteins, to do things within the cell, or to make the cell grow or die or produce other enzymes. But also RNA actually can leak out of the cells and into the circulation. So this means that we can get a picture in the peripheral blood circulation of what's happening inside the nucleus of the cell and what the cell's doing. And there's tens of thousands of these things called microRNAs, and we don't really know what they do, but we know that they do influence certain processes in cells, and as a result, different diseases have a different signature of these RNAs. If there's tens of thousands of them, some of them go up in certain disease processes and other ones go down. And we're just starting to begin to understand the potential for microRNAs, particularly circulating microRNAs, in their potential in diagnosis and monitoring of liver disease. So we can actually look at the signature or the profile. This is an example in biliary atresia. So this study looked at, can we differentiate biliary atresia from other diseases causing cholestasis in babies by looking at blood microRNAs. And they found that these three particular microRNAs were significantly higher in the patients with biliary atresia, that's the grey bars, than the other babies who were cholestatic from other causes. Still in its early days, this isn't being used in clinical practice yet, but I think this is an area that we're going to see, I predict we'll see non-invasive diagnosis. And that's also, I should mention, this has been shown to be useful in some studies of transplant rejection as well. So I think that's the other area where we're going to see this in the future. The future of treatment, well, we can think of it broadly about drug therapy. So we have better drugs nowadays, and there's some new classes of drugs that actually make use of what we've got. So, for example, cystic fibrosis is probably an example of this. There's some new drugs that are being tested recently and shown to be very effective at actually enhancing the proteins that are mutated and not working so well, giving them a bit of a kickstart, putting them in the right place in the cell and making use of what function they have. And that's the drugs known as ivacaftor or lumacaftor that have been shown to put the mutated protein in the right spot, make it work a little bit better, and that's been shown to improve lung function in children with cystic fibrosis, a genetic disease with particular mutations. This is a new class of drugs that we call potentiators or correctors. It's still unknown at this stage whether this might actually help children and adults with CF-related liver disease. Anecdotally, I think it does. I've seen a few CF kids on these drugs whose lungs seem to get better, and when we look at their liver function tests, they seem to have got better. But I think we'll see some more studies about that. But I think this principle of potentiating or correcting defective proteins will probably be exploited in the future, perhaps with conditions like alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency, as some of you will know, is a liver disease that's caused by an accumulation of this defective protein. It gets stuck within the liver cell, makes the liver cell sick. It's a normal protein that the liver makes and puts out into the circulation. It can cause lung disease and liver disease. And there's actually a current human study being run from the US that's enrolling patients with alpha-1 antitrypsin liver disease to look at a drug called carbamazepine, which is an anticonvulsant that's been around for 30 or 40 years. But it seems that this drug actually works by activating housekeeping genes within the cell. So with alpha-1, you have these accumulated proteins causing bunging up the liver cell. Let's improve the housekeeping in the cell and clean the stuff out. So that's been shown to have potential in animal studies, and there's a human study going on at the moment. The third arm where I can see drug therapy improving in the future is actually replacing missing enzymes, and we have proof of principle already. There's a couple of metabolic liver disease where we don't make the right enzymes in the liver and the liver cell doesn't work very well or perform its function. More recently, one of those is a disease called acid lipase deficiency. We have a patient in Newcastle who is involved in an international multicentre study getting that replacement enzyme, and it seems to have worked. He had a liver full of fat and elevated serum cholesterol, was looking at potentially a life of having early strokes and cardiac disease because of his lipid problems. His liver's back to normal and his cholesterol's normal after 2 years on the treatment. So I think this principle again might apply to other metabolic liver diseases in the future. The future, gene therapy. So that's a really, really exciting area, and we have some local expertise in Australia and in Sydney in this area. So the idea with gene therapy is that we use a vector, as it's known, or which is basically a virus. You somehow get that virus, convince the virus to carry a copy of the correct gene into the liver cell or the other cell, whichever condition you're trying to work with, and make the liver cell incorporate that gene into its DNA. So therefore knocking out the defective gene and putting in a good copy of the gene. The advantage of gene therapy is that it's non-invasive. It's just infecting somebody with a virus that you've engineered in the lab. You can make it specific to target very specific genes. The challenges, however, to gene therapy, and this concept has been around for a long time, and I guess the reason we're not seeing it in practice is that the difficulties of actually directing the virus to the correct cell, so making sure the virus carries the gene into the liver cells and not brain cells or other cells where you don't want to be messing around. Also getting the new gene expressed, so that means you can put the gene into the nucleus, but getting the rest of the cell to say, okay, let's use this gene now and let's start making proteins or whatnot from that gene. And getting them to do that in enough levels to prevent the disease. There's also issues about long-term safety. So what's going to happen? Are there some other, effects that you didn't anticipate when you're mucking around with the genetic material within a cell? It has, however, been used in animal studies for these liver diseases, Crigler-Najjar syndrome, glycogen storage disease type 1, haemophilia, which is not a liver disease, but a lot of factor VIII is made within the liver, familial hypercholesterolemia, a number of urea cycle disorders such as OTC deficiency, and Professor Ian Alexander at Westmead, he's internationally recognised as working on this area and has cured some rats of OTC deficiency, and I think they're looking at children or humans as now. Porphyria, alpha-1 antitrypsin deficiency, it has been looked at, but only looking at the lung function in adults. So very early days yet, but exciting stuff for the future. Finally, in the last few minutes, I'll talk about transplantation and what might be on the horizon there. So really, we can think about transplantation as actually managing what we currently do, transplanting organs in surgically, and then other avenues. So better immunosuppressive drugs are one aspect where we can see some improvement. The improvement since from cyclosporin to tacrolimus has been really, really good, but tacrolimus is the current standard of immunosuppressive treatment, and there are recognised toxicities and side effects using it long term. So better immunosuppressive drugs will target key rejection processes without causing other side effects. That's what we're after. There's the idea of no or less immunosuppression, and Michael's talk covered that as to who might be able to come off immunosuppression, and also whether we can individualise dosage. At the moment, we just know things like, oh, well, if we keep the tacrolimus between this number and that number, you're generally going to be okay, but that may not apply to one person as it applies to another. So looking at the individual patient and their genetic makeup might affect what target level you go for. Then finally, tolerance, which Michael also mentioned, which is convincing the immune system not to cause rejection. So there's different things that have been looked at to induce tolerance in animal studies, such as infusing donor cells from the bone marrow, or also expanding a type of immune cell that we all have called a Treg cell or a regulatory T cell, and these are like the hostage negotiating cells of our immune system that calm everything down. The future of transplantation may involve liver cell transplantation, and there's some work being done there. So the idea with this is that healthy liver cells are transplanted rather than the whole liver. And the advantage of this is that it could be done relatively non-invasively, just by infusing a whole bunch of cells in a solution straight into your portal vein, and then the portal vein goes straight to the liver, so the little liver cells go into the liver, set up camp there, and hopefully multiply and make more good cells that are working. An advantage, of course, is that you don't have to pull out the old liver, and it's good for conditions where the liver is otherwise working well, like metabolic liver diseases, and it's not really sick and cirrhotic, or where you might have recovery of the liver. So this has been used in acute liver failure situations where there may be some recovery. The barriers, though, to overcome is that to get it to take over and do the normal function of the liver, we need loads and loads of these cells. So in places that have started doing this experimentally, they found that up to 1 billion cells per infusion are required. So where are we going to get all of those cells from? They can melt down donor livers and apply enzymes to break them down to their hepatocytes, but those liver cells may not be that happy about all of that by the time they reach the liver, and they may not be willing to work. There's also rejection as well, particularly if the cells are coming from a person that's not you. So we still face the problem with immunosuppression, and then we have the disadvantage, though, we can't do a liver biopsy and see what's happening with rejection, because these guys are spread out throughout the whole liver, so you're picking off, your immune system's picking off all these billions of cells in various locations. Controlling where the cells end up can be difficult if you infuse them to the portal vein but the person has liver disease and some of that liver flow is diverted away from the liver. They might end up in other spots. There's also the long-term survival of the transplanted cells, and monitoring if they're still there. And how do we get the transplanted cells to take over? How can we get them to have an advantage over the native liver cells? It's been used in animal models of Wilson disease, hereditary tyrosinemia, Crigler-Najjar syndrome and acute liver failure. And there's some case reports in humans for acute liver failure and Crigler-Najjar. An emerging technology in parallel with this is this idea of induced pluripotent stem cells. So this might get around the issue of rejection. So with this, you would take a biopsy from the person who's sick. So if I had liver failure, you'd take a skin biopsy from me, find some cells from there, put them in the lab, make them turn back into stem cells, and then make them forward into hepatocytes and liver cells. So you could actually culture in the lab your billions of cells that are my cells that I'm not going to then reject and put them in. So that's an exciting thing that's still way off in the future, but the idea is there. And also in the distant future, can we generate artificial organs? Can we make them, in the lab, in the factory, and just sort of stick them in? So there's people working on 3D printing technology. Instead of putting blobs of plastic, actually putting individual cells using like a modified bubble jet printer that sits there and puts the right cells in the right spot next to each other. So 3D printing technology is starting to be used. Currently it's only in its very, very early stages, and mainly it's been used to get somebody's cells and make a dish full of hepatocytes and see how they respond to drugs. But that's in the distant future. So the future's pretty bright, and as to quote people, the current Prime Minister, it's never been more an exciting time to have liver disease, if I can say that. Because there's lots of exciting things around. So thanks a lot for your time, and thanks for the organisers.